Alrighty. Hello, everyone. I'm Miranda Nabulsi. I'm one of the board interns for the school year for PPS, and welcome to the Week 5 general meeting for Pre-Pharmacy Society. I'm going to be presenting this intro PowerPoint along with Michaela and Christine. Alrighty, so here on slide 1, we just show how to become a paid member. So step 1 is you could fill out the PPS membership form, which you can find the link for in our weekly emails and on the Pre-Pharmacy Society website. And secondly, you can pay your membership fee to PPS at UCI on Venmo. And thirdly, after signing the membership form, you can go ahead, there we go. Okay, so thirdly, after signing the form, you can go ahead and contact the internal vice president, who is Allie Mills, to pick up your membership t-shirt or your member t-shirt or have it shipped to you. And lastly, you can keep track of your stamps using the virtual stamp sheet. Alrighty, so on this slide here, we have a PTCB question of the week, and these are just questions that come from, former pharmacy technician certification board exams, which I'm assuming a lot of people pre-pharmacy want to become pharmacy technicians. So these will just give you a good idea of the questions to expect. So for this week's question, we have here, what type of injectable water is intended to be used for injections, which is A, sterile water for irrigation, B, purified water, C, bacteriostatic water, and D, water for injection. And I believe there should be a poll and everyone can go ahead and take a minute to choose. Alrighty, so it looks like a lot of people have answered. Looks like D was the most popular choice, water for injection. And if you go to the next slide, we'll actually see the right answer was bacteriostatic water. So good job, everyone. And right here, I'll pass it off to Michaela, who is one of the social chairs for Pre-Pharmacy Society.
Okay, this is a recap of our last week meeting, which was the week 4 general meeting. So thank you for everyone for coming out to our week 4 general meeting with AIP. We hope you learned a lot on how to connect with UCI alumni through the Anteater network. One of our upcoming events is our after social after this general meeting. It's going to be on Discord, and it is Cards Against Humanities. So feel free to stick around and play a game of Cards Against Humanities with us. Another upcoming event is our week 6 general meeting. It is next week, February 10th from 6 to 7. It's going to be the same Zoom link meeting. What is about? It's Western U CSHP chapter will be presenting about California Society of Health System Pharmacists and sharing what health system pharmacists are involved in. Paid member, why you should come is because paid members will receive a stamp for attending and also learn about health system pharmacists. And if you have any questions, comments, and concern, please contact our external vice president, Dana, at her email.
Hello, everyone. So a volunteering event we have is called Coach Art. It is a wonderful opportunity to virtually teach a young individual that is impacted by chronic illness about various activities, including sports, arts, or cooking. And by doing so, you'll really help these kids see themselves more as athletes and artists and less as patients. And you can choose any time to volunteer your time. One of the listed requirements is to provide 8 one-hour lessons for the young individual. If you are interested, please visit the attached website for more information. Paid members will receive a stamp by filling out the attached Google form and sending a screenshot of proof that you have applied by February 10th, 11:59 p.m. next week. If you have any additional questions, comments, or concerns, please contact our president, Jenny, at the following email. And we would also like to thank those who have ordered PPS hoodies. You should have received a confirmation email last winter. They are now ready for delivery and pickup. So if you have any additional questions about your particular order, feel free to message me at the following email.
Hello everyone, it's your fundraising chair here. So right now we're doing a Jamba Juice BOGO card fundraiser. So by these cards basically allows you to buy one and get one free for 6 times, just for $10 each, and each card will be worth $35, and it's so the 6 additional drinks per drink purchased. So if you're interested, please fill out the purchase form to claim your GC deal in the link, and we can also. So you have 3 methods of obtaining the code. We can either send it to you through email or deliver the card, which also includes $1 shipping, or you want to just pick it up on campus. So if you have any questions, comments, or concerns, please contact please contact me, Ryan, at my email. Another fundraising event we're doing today is that we are doing this I Love My Org competition hosted by UCI COVP. We'll basically just take a photo at the end where you guys will perform, when we have all the same Zoom background with camera on, where we can just wear one of these themes of wearing winter accessories, bringing a PPS merch or item, or having your small hearts or like Zod sign. And if you would like to participate in it at the end of the general meeting, feel free to do so. And also, you can go support PPS when our post is up on their Instagram page on February 8th, 2021 at 12 p.m. at UCI COVP.
And you can stay connected with us through these various platforms, including our Facebook, Instagram, Discord servers, website, Zoom study room, and Spotify collaborative playlist. These are clickable links on the slides, and they're also provided in the emails. And now, without further ado, please give a warm welcome to Dr. Erin Knox. Hello.
Hi there. I am going to, there we go. Now I can share. I was waiting for you to stop. Hi, everyone. Thank you guys for being here. It's great to see so many tiny little boxes of faces. I am Erin Knox. I'm currently the Director of Experiential Education at the UCI School of Pharmacy. But I'm going to talk to you guys a little bit about what my journey has been getting here, including my pharmacy school education, my residency, and my previous positions. So as an overview, we'll talk about psychiatric pharmacy, what that means, and then how that was integrated into my journey through my career so far. So many of you have probably heard about psychiatric pharmacy, if nothing else in the context of Dr. Larry Plon, who is also a psychiatric pharmacist and is involved with you guys as pharm-sci majors. Psychiatric pharmacy really refers to specialized pharmacists who have a specific skill in treating mental health or psychiatric patients. It was previously called psychopharmacy, and for obvious reasons, it was kind of formalized into psychiatric pharmacy, which sounds a little bit more refined. With psychiatric pharmacists, generally speaking, we will manage psychiatric illnesses, including major depression, bipolar disorder, which is a particular interest of mine, schizophrenia, anxiety disorders, and personality disorders certainly play a role. There is a huge dual diagnosis focus for substance use disorders. Traumatic brain injury and neurological conditions such as dementia can also be areas of focus. And then eating disorders can also be something that psychiatric pharmacists will be involved with treating. And this sounds like a lot of brain diseases, which it is. $225 billion was spent in the US on mental health. And in any given year, 40 million plus adults will experience mental illness. That includes depression, anxiety, and some of the more persistent and severe mental illnesses like schizophrenia. So psychiatric pharmacists can practice in all kinds of different settings. There are a lot of psychiatric pharmacists in VAs, which is a government-supported hospital, some state hospitals such as Patton or Atascadero. There are public, private, and academic hospitals that all have psychiatric pharmacists. So public hospitals being something like the Los Angeles County hospitals, there's psychiatry in the general hospitals as well as psychiatrically focused hospitals. Private hospitals such as Huntington Memorial in Pasadena, and then academic hospitals, which would be something like Keck Hospital at USC or UCI, the two areas where I've primarily practiced. You can find psychiatric pharmacists in outpatient clinics, mental health clinics, primary care clinics, and sometimes specialized care clinics. And there are also psychiatric pharmacists involved with correctional facilities or prisons. Occasionally, you'll see eating disorders clinics that have psychiatric pharmacists, whether or not they're there full time. They may be involved as consultants. And something I didn't list on here is pediatric and adolescent care. Pediatric and adolescent psychiatry is much more of a subspecialty within the specialty of psychiatric pharmacy. And some of my close colleagues actually work in pediatric psychiatric pharmacy. So what does a psychiatric pharmacist do? And if this were in person, I would ask you guys just to throw some things out, but that doesn't work as well in Zoom because then people start talking over each other. It's a little bit harder. Some of the things might seem obvious. We manage and oversee medication use for patients under psychiatric care. We do medication education, and psychiatric pharmacists are really, really important with medication education because we spend a lot of time learning how to use terminology that makes sense to patients, particularly those who have a psychiatric illness that affects their ability to maybe understand some more complex terms, or psychiatric conditions that may have affected their ability to obtain an education beyond even middle school or into high school. So we work on communicating this information in patient-friendly terms, also learning how to communicate that in the context of symptoms that can lead to poor adherence. So a patient, for example, with schizophrenia may hear voices that are command auditory hallucinations telling them they're trying to poison you, don't take the medication. And that can significantly impact our ability to communicate important information to the patient so they understand the importance of adherence. In addition, a lot of terms used in psychiatry are unfortunately used in much more casual situations, and they're used incorrectly. So I can't see too many of you guys, but I want everyone to just stop and think about some of the terms that you've used. In the last week, have you used the term antisocial? Stop being antisocial. Go on the Discord or go on the Zoom. Has everyone used that sometime in the last couple weeks? Antisocial is a psychiatric term. Antisocial is actually a term for someone who has a personality disorder. Or someone might say, oh, I have OCD, because they were busy organizing something, their desk, their closet, their notes. But in reality, it's probably not OCD. Or, oh my gosh, my anxiety is out of control. Okay, it absolutely could be. And that's probably something that we're all a little bit more comfortable using because we're more familiar with that term. So that's just an illustration of your comfort of terms and how closely they may actually align with psychiatric conditions and true psychiatric definitions. So medication education, but also psychiatric jargon education is something that we will commonly be involved with in regards to psychiatric patient care. I'll share a slide with some of the medication education that I've done so we can talk about some of the techniques that we use. Psychiatric pharmacists can be involved with the initiation and prescribing of medications, the monitoring and dose adjustments. So for example, a psychiatric pharmacist in a clinic could be involved with a referral where a patient comes in and they select the best medication, they start it, They talk to the patient about what to expect, and they'll see the patient at follow-up meetings for monitoring and adjustment. This could be via telehealth, or this could be in person. Some of the important things that we do, especially on an inpatient unit, is managing adverse effects. So when people have problems with their medications, the psychiatric pharmacist is the first person in a psychiatric care facility to go to of how to manage. In addition, drug interactions can be pretty significant. Some of our medications can be significantly affected by a medication as common as ibuprofen. That can have a very severe interaction with something like lithium, which is a common psychiatric medication. And so it's important that the psychiatric pharmacist not only be aware of those, but be able to manage those interactions. A psychiatric pharmacist may be available for consultation. There are a lot of clinics that are medically complex psychiatric consult clinics. And this can be because psychiatrists in general spend their time training on psychiatry. But even psychiatric pharmacists are fairly well versed on medications used for medical conditions. So you might have a patient with diabetes, and most psychiatrists feel comfortable enough, not necessarily managing the diabetes, but being familiar with it. But what if you have a patient who has a solid organ transplant or is undergoing chemotherapy? Those more medically complex patients may require the intervention of a psychiatric pharmacist to help manage the psychiatric medications. There's something called medication-assisted treatment, which is used for patients with substance use disorders. Psychiatric pharmacists can also be involved with medication administration. There are a few local pharmacies that will administer long-acting injectable antipsychotic medications for patients with schizophrenia or bipolar disorder. And they do that right there in the pharmacy. So a patient will come in for their monthly medication administration. And that's something that is commonly done as somewhat of a crossover between community pharmacy practice and psychiatric pharmacy practice. So I promised I was going to talk a little bit about medication education groups. This is a poster that I presented at the UCI Health Safety and Quality meeting in September of 2019. So I started working on this with a pharmacy student who at the time was a first-year student, and her name is Mary Yosef. So I guess she's a third or fourth year now. And then at the time, there was a PharmD candidate named Dara Nguyen. We worked on this kind of sequentially. So Mary was involved with some of the initial data collection. Dara, when she came along about 3 months later, was involved with kind of finalizing and perfecting the poster. So this talked about some of the medication education groups that I provided at UCI Health directly to patients. And it's hard to see, I understand, I'm sorry that it's tiny, but some of the things that we do to engage our patients will be word searches, where we have varying levels of difficulty. So hopefully you guys can put this in the chat. Here's a question for you. I probably should have done this as a poll question, apologies. Who do you think, from a patient population perspective, would be able to do the difficult word searches or the difficult crossword puzzles? Do you think the adult patients would be better at it? Or do you think the adolescents, age 12 to 17, would be better? Anyone want to venture to guess? Either unmute themselves or put it in the chat. Let's see. We've got a couple things. Yeah, adolescents. So this is something that tends to be surprising to people. We've got 4 total answers, and it looks like everyone is saying adolescents. That's absolutely correct. So it's a bit counterintuitive because you would think, okay, someone's 24, they're probably better than a 12-year-old at a difficult crossword. But the problem is when you have adult patients with psychiatric illness, they often have lingering and continuously progressive cognitive effects, meaning they have a much more difficult time processing information, maybe recognizing patterns in something like a crossword puzzle. And unfortunately, what some things like movies have showed us is, you know, someone with schizophrenia like John Nash in A Beautiful Mind, he can just look and see all these patterns, so he should be great at a crossword puzzle. And maybe early in their disease state, they might. But these are progressive chronic conditions that get progressively worse and progressively worsen cognition of your patient. Therefore, by the time they're in their late 20s, early 30s, they start having difficulty with things like crossword puzzles and word searches. So we have various levels of intensity for these, and we have different answers. When we're talking about the pediatric and adolescent population, what we tend to see is a high incidence of substance abuse disorders, depression, and suicidality. We don't have as many 14 and 15-year-olds with diagnosed bipolar disorder or diagnosed schizophrenia. And those tend to be the conditions that are more likely to worsen cognition, schizophrenia in particular. But when we start talking about the adult population, and we're talking about 25 to 45-year-olds, well, they're more likely to be in a psychiatric hospital because of something like schizophrenia or bipolar disorder, and therefore they're more likely to have those cognitive impacts. So we're going to have different answers, different medications, different information in there because adolescents and adults are going to need very different types of education. One of the things that I found with the adolescents is they're really excited to talk to someone who knows about medication, possibly without an adult present. So if you think about 16-year-olds, there might be a lot of questions about sexual health. And what we found is a lot of them also have questions about substances of abuse, illicit substances that they may have used. They maybe don't want to ask that question of the psychiatrist because they're afraid it's going to get back to their caregivers, their parents, their family members. And so we would get a lot of questions about birth control. We get a lot of questions about what happens if I smoke pot every day? What is it really doing to my brain? And I read this, I read that, I heard this on a podcast. Is this true? And you don't get that as much with the adults. They're able to find that information on their own. Now it's a little hard to see, but these 3 prescription vials here in the middle of this poster are actually for Mickey Mouse. And they each have a different medication name on them with instructions. And what I would do is take these to the groups and pass them out to the patients. And we would do one of 2 things. We would ask them to extract relevant information from the prescription label. And we would ask, can you find the name of the prescriber? Can you find how many refills are left? Can you tell me how to take this medication? Can you tell me how to store it? What is the pill inside supposed to look like? And many patients had a very difficult time identifying that information. So it was a great exercise in a crossover between psychiatric pharmacy as well as occupational health. If anyone's ever been involved with occupational therapy, that's something that OTs do. Very practical, very applied skills. And so it was great for the patients to learn how to identify that information, because if they can find that information on their prescription vial, they're much more likely to be able to communicate it to their healthcare providers. And so when we did this poster, we put all of the techniques that we used, well, maybe not every single version, but we included some of the techniques we used in medication groups. So we were able to describe them from a patient safety perspective. We were able to show that it was approximately 70-something% of the patients who were eligible to go to medication groups attended. Obviously, various degrees of participation, depending on their motivation, depending on their condition. But we were able to touch at one point 70% of the patients. So have a point of contact with almost 3/4 of our patients, which we considered a win. All right, let's go on to medication prescribing. So I briefly alluded to this where I talked about if you're in a clinic, you can have a referral from a diagnosing prescriber. This diagnostician could be a psychiatrist, sometimes NPs, PAs, or psychologists. They may refer a patient to you and say, hey, I need to get this patient on something. Their current diagnosis is bipolar disorder. Can you help me get medication started and continue to follow the patient? This is very common in many of the safety net clinics. I do have a couple colleagues who have their own cohort of patients. They basically have a clinic, and the psychiatrist and psychologist in the clinic will refer patients over to them so that they can continue to follow. They'll do things like symptom assessment, do rating scales, which is essentially the closest thing to objective information we have in psychiatry. And these pharmacists will also do labs if needed and interpret the labs, seeing the patients for routine follow-up. I mentioned complex patients. So we talked about potential solid organ transplant patients as medically complex, but also some patients who have multiple disease states, where it can be a little bit tricky to figure out how to manage their 17 or 18 other medications and which medication is best and what to do to monitor. If there's no one best medication, what do you do about those drug interactions? And oftentimes psychiatric pharmacists involved in medically complex patient care clinics will be the ones doing the majority of the medication management. There's also potential for involvement with rare diseases, and I'll talk about that in just a couple minutes when I talk about my journey. This is a brief slide on medication-assisted treatment. If anyone is really interested in substance use disorders and how psychiatric pharmacists can be involved, I'll tell you guys at the end of the presentation about a great website for psychiatric pharmacy, and one of my former residents is featured on there for the medication-assisted treatment that he does. For medication administration, I talked about long-acting injectable antipsychotics. This can be in pharmacies. There are also some psychiatric pharmacists who go around in a mobile van where they administer the long-acting injectable at the point of the patient's residence. And that residence could be without a home. These could be patients without permanent housing. But oftentimes what we find is many of our patients who do not have permanent and consistent housing stay in the same general area. You guys are probably familiar with the riverbed area near Orange over by Anaheim Stadium. And there were several homeless patients who had lived there consistently, and they didn't really go that far. So it was pretty easy to find your patient. If you knew where they were once, they were likely to be in that same area because it's familiar to them. So some of the pharmacists will go in the mobile van and administer the long-acting injectable antipsychotics. All right, so that was a brief overview. So I'll talk a little bit about my journey and what I've done as far as psychiatric pharmacy practice. So I started at USC in undergrad, went and got my PharmD from the USC School of Pharmacy. And somewhere around there, actually in undergrad, I know I wanted to go and do CNS research. I wanted to be involved with research regarding substances of abuse. I was really interested in that. And then I got to USC and I realized what that research was going to entail. And I was like, yeah, that's not for me. I don't know if I want to do research. And I got to pharmacy school and I thought, the reason I don't want to do research is I want to engage with people. And one of the things that you're going to find with psychiatric pharmacy and everything that I have mentioned so far is it involves talking to your patients. So I'll talk about this in a minute. Don't get me wrong. I absolutely love critical care, but in critical care, you can treat a chart. You may never know what that patient's face looks like. You may not know their story. You may not know the true humanity behind it. It's easier to be somewhat separate from your patient because they may be on events in an ICU, sedated. So you don't get to interact with them. You're interacting with the physicians and the nurses. But in psychiatry, you have to talk to your patient. There's no hope to appropriately treat a patient, to adequately assess them unless you speak to your patient. And I really enjoyed that aspect of psychiatry. So at some point in pharmacy school, I decided psychiatric pharmacy was for me. Dr. Susie Park, who I mentioned to some of the people in the breakout room, who I think has spoken to you guys before, was influential in that. She lectured when I was at USC, and I was like, wow, that's who I want to be like. So all the psych people, I really liked what they did, and I also thought I want to be like them. So I did my residency, and it was based at LA County USC Hospital, which is that picture there on the right. And at the time, it was a one-year residency. So I graduated in 2003. And it was a little bit different then because now psychiatric pharmacists actually have to do 2 years. Oh, I have something in the chat here. Psychiatric pharmacy has to do 2 years. You do 1 year of either ambulatory care or acute care, and then you do a second year in psychiatric specialization. So after I finished my residency, I was hired at Keck Hospital of USC, which at the time was USC University Hospital. And it was actually a former preceptor of mine for my medicine rotation who said, hey, Erin, I'd love for you to come over and cover psych. We had a small inpatient psych unit, was also able to be involved with psychiatry consults for the very high acuity critical care patients there at Keck Hospital. And then over the course of my 14 years there, got involved with the Cystic Fibrosis Collaborative. So if anyone is familiar with cystic fibrosis, it's a rare disease, it's genetic, and there's a really high incidence in this patient population of depression and anxiety disorders. And these are patients who are treated from a very young age. Since it is genetic, this is something that's initially treated oftentimes as a pediatric patient. So they spend a lot of time in the hospital. And if you think about children in the hospital, if anyone has ever been involved with pediatric hospitals, they are super warm and welcoming. We give them Lego, we give them toys, they have video games. Everyone tries to make it a really positive experience so that the child won't be afraid to come to the hospital. So with our cystic fibrosis patients, usually around the age of 18 or 19, they transition from a children's hospital to an adult hospital. Well, unfortunately, adult hospitals aren't like that. We're not trying to make anyone stay longer. We're trying to get you out. So it's not as warm. It's not as welcoming. You don't get toys. You don't get video games. And it can be a little bit of a harsh wake-up call for these patients. So the hospitalizations for our cystic fibrosis patients are very difficult. They tend to be long, like 2 weeks. Plus, on top of that, they have this chronic long-term debilitating disease that they know is eventually going to take their lives much younger than their peers. So it can be a very difficult disease to manage. The cystic fibrosis team recognized this and said, hey, psych, we need your help. And I was in a perfect position since, if you look at the second to last bullet point, I was covering a pulmonary ICU as a critical care pharmacist for the other part of my day. I was in a perfect position to cover both. I knew the cystic fibrosis treatments, I knew the patients pretty well from the ICU, and I knew psychiatry. So I was able to sit with the patients and really empathize with what they were going through. Now, while I was at Keck Hospital, I also taught at the School of Pharmacy. I had residents and students. But after 14 years there, doing a lot of critical care and psychiatry, I was ready for a little bit of a change. And so I transitioned over to UCI Medical Center. And this was a brief stay. I was only there for 2 years. I covered inpatient psychiatry, a little bit of psych consults, psychiatric emergency department, and my primary role was actually student program development. So the idea behind my position as a pharmacy education specialist was to help build up the student program in anticipation of the School of Pharmacy. Well, then this position became available and I was like, this is just kind of a natural transition. That sounds fantastic. I want to be involved from the ground up. So I took a position as Director of Experiential Education. And what that means is even though we don't have any students in our PharmD program, I'm working to develop affiliations with the outside hospitals, outside pharmacies, independent and chain pharmacies. I am creating the syllabi for our experiential courses, which is a whole separate topic. I'm working with our established as well as some of our new pharmacists to do preceptor development. And I've been in this role for just about 6 months now, and I'm getting ready to go back to a psychiatry practice, most likely in an outpatient clinic at UCI Medical Center. We're kind of hashing out what exactly that's going to look like, but I'm really excited to get back into it because it's been a few months since I've done anything other than text message consults. So what makes me a psych pharmacist? What means that I can call myself that? Well, I'm board certified in psychiatric pharmacy, which means we have to renew every 7 years. You have to do 100 hours of specialized continuing education sessions, and you have to have a current practice site. So even though mine's on pause, over the course of the 7 years, I've had a current psychiatric practice site. And this is the organization that I would encourage anyone with a strong interest to look into. So it's the College of Psychiatric and Neurologic Pharmacists. And if you go to their site, which is just cpnp.org, you'll find profiles of practicing psychiatric pharmacists, including people working in the VA, people doing medication-assisted therapy, people working in clinics, and people working in academia. So if you find the medication-assisted treatment pharmacist who is highlighted on there, Dr. Seth Gomez, I've worked with him and he's doing amazing things up in Northern California. So CPNP is focused on providing support, education, and lots of networking opportunities for psychiatric and neurologic pharmacists. Just to wrap up, to give you guys an idea of what the scope is of psychiatric pharmacy, there are just over 1,000 board certified psychiatric pharmacists I think it's worldwide. There are a few in some other countries. There are several in Canada. I know there's at least one in Singapore. That's not that many. When you think about how many pharmacists there are, and there are, maybe 1,100 or so board certified psychiatric pharmacists, it's a pretty small group. So there are a lot of connections to be made there. If you're interested in a particular geographical area, we can probably find a psychiatric pharmacist to put you in touch with. It's a great resource. It's an excellent conference that they have every year where you just get to do all psych all day for 4 days. So it's like the highlight of my year from a professional perspective. Unfortunately, it's all virtual, much like everything else. But we do have student chapters at many schools of pharmacy. So if you do pursue pharmacy, there are student chapters of CPNP, and there are lots of student opportunities at the conferences as well as throughout the year for networking and interaction with psychiatric pharmacists. So I suppose I'm right on time, and it is time for questions. And I'm sure you guys have some excellent ones, so challenge me.
Hi, if anyone wants to go first. If not, I guess I could go. Hi, Dr. Knox. So I have 2 questions. Maybe that's 3, but like the 2 and third one is kind of connected, because personally I'm very interested in the field too. So I just want to try to learn more as much as possible. So the first question is, what are some opportunities that an undergrad can do if they're interested in it?
So the main opportunities, I would say, as far as involvement, I would encourage you to look into NAMI, which is the National Alliance for Mental Illness. It's NAMI.org. They have local chapters. There's a ton of information on there associated with supporting family members or those experiencing mental illness. CPNP has primarily just provided support for students in pharmacy school who have an interest in psychiatric pharmacy. I would say, though, that this is an area that can be very difficult to obtain shadowing opportunities, because in general, psychiatric care is an additional layer of security clearance. So for example, if you work at a hospital, you'll have access to full medical records, but you have to put in a separate level of clearance to get access to psychiatric patient care. And that's just because of the unfortunate stigma associated with the brain diseases that are classified as psychiatric conditions. Part of that, unfortunately, is the history of psychiatry, and the stigma has kind of carried through.
All right, thank you so much. That was very helpful.
Was that
and the
all
second
3 questions? Oh, okay.
No, okay, sorry, no. But the second and kind of third question is like, what are the majority cases do you usually deal with? Is this more like inpatient or outpatient? Because you like to talk about both.
Mm-hmm.
And that kind of correlates to your first year of residency. It's like, does doing AM care or acute care as first year residency matters a lot, or yeah?
So I would say the current trend is most second-year residents in psychiatry did an ambulatory care residency as their first year. There are several programs that offer an early commitment for their ambulatory care residents carrying on into a PGY2, postgraduate year 2, residency in psychiatric pharmacy. I would say that the reason for that is a lot of psychiatric care has shifted to the community, and ambulatory care has picked up a lot of the patient care responsibilities for patients with mental illnesses. Now, that being said, if you had asked me 7 years ago, I would have said acute care, because I am a bit skewed. Most of my experience has been in high acuity inpatient types of settings. And so when you're dealing with patient populations for inpatient, on an inpatient psychiatry unit, you're going to see major depression, schizophrenia, and bipolar disorder. And oftentimes you will see comorbid substance abuse disorders in those patients. If you're talking about acute care medical facilities, like my setting at Keck Hospital at USC, I would see a lot of acute agitation and delirium, which is often associated with their medical conditions. The other things that we would see is concerns and questions about how to manage maintenance psychiatric care in a medically ill patient, even if they're not acutely experiencing symptoms. The idea is preventing those symptoms. And then when you look at cardiac care units, you have a really high incidence of depression. And so some awareness of monitoring those patients in the immediate post-operative and cardiac care period is of quite a bit importance to teams like cardiology and cardiothoracic surgery. So at Keck Hospital, those were the types of patients that I saw. Now, when we had the inpatient unit over at Keck Hospital, we saw a lot of patients with dementia because we had one particular psychiatrist who was a geriatric psychiatrist. And so he brought in a lot of patients with different types of dementia. And I will say that both facilities at which I've practiced, Keck Hospital of USC as well as UCI, we've offered electroconvulsive therapy, which is ECT. Many of you guys have probably, unfortunately, seen some of that in movies where we do things that maybe aren't really how current practice is reflected. But we did that at both facilities. So we would see some fairly resistant patients as far as their psychiatric conditions referred over to get ECT. And so that's the makeup of the patients that I saw. Now in clinics, you're going to see a mix and it's going to depend. You could see more stable schizophrenia patients. You might see a high incidence of anxiety and depression. Clinics can vary significantly and run the entire range of psychiatric conditions.
Thank you. Thank you so much.
Sure. Thank you. Now we have a question. He says, what's the difference between a psychiatrist and a psychiatric pharmacist? Well, a psychiatrist goes through medical school and then does a residency in psychiatry. So they would be MDs or DOs, and pharmacists go to pharmacy school and then do a 2-year residency training track to focus on psychiatry. So as far as what the practice can look like, psychiatric pharmacists generally, not all, but generally don't do therapy. On that subject, though, many psychiatrists actually don't do therapy. So it's not a requirement as a psychiatrist, as a physician, to do therapy, but they have the opportunity to be trained in that. In addition, they don't need collaborative practice agreements. For psychiatric pharmacists, there's often an agreement in place that allows us to prescribe and monitor. I think that was the only question in the chat. Any other questions?
Hello, Dr. Knox. I was wondering, like, branching off of the medical education and like mental illness stigma, how do you think we could address like the mental illness stigma?
So there are some hotly debated conversations about this, Christine. Thank you for bringing this up. There are many people who work in psychiatry who hate the idea of even discussing stigma, because they think talking about stigma reinforces it. And the idea behind that is to normalize the discussion, right? This is not stigma. Don't give it mystique. Don't give it more power. Just talk about it. It's fine. However, I think not recognizing the stigma can also do a disservice, because you have to recognize that people might be uncomfortable with it. And so for me, the first step is kind of recognizing how you might be contributing to stigma. And that's why I asked all of you if you've used the term antisocial. So to revisit that, I have a great story. I had a student at USC who was a 4th-year student with me, and she was really, really great on rotation. And she went to lunch in the cafeteria, and she sat at a table adjacent to a medical student and the psychiatry attending. And he turned to her and said, "Why are you being antisocial? Why are you sitting over there? Come sit with us." And she said, "Dr. Diaz, don't you mean asocial, not antisocial?" So she corrected a psychiatry attending who used the word incorrectly. And he said, "Yeah, whatever, I'm at lunch, I'm on break." So, I mean, it was pretty brave of her to do that, but she was correct. He was using the terminology incorrectly. He was using it the way we all do. So antisocial really is someone who's anti-society. So someone who is not adhering and not abiding by society standards and norms, hence anti-society, antisocial. Asocial, as you guys are probably familiar, when you talk about something and you put an A in front of it, it means you're lacking. So asociality is lacking social interactions. So someone who doesn't feel like interacting, who kind of wants to stay home, they're not really rebelling against society standards and norms. They're just withdrawing from society. And so they're reflecting more of an asociality. So I think recognizing how we use these terms incorrectly is important when we talk about contributing to eliminating the stigma. We have to be careful though, because there is almost a swing towards over normalizing symptoms where people attribute kind of their everyday ups and downs to a psychiatric condition, which dilutes out the severity of psychiatric conditions. Yeah, you might be having a really tough time. It's a really tough semester or quarter. I'm sorry, you guys are on a quarter system. Really tough quarter. And I'm not feeling my best. Okay, so someone might look at that and say, oh, I'm so depressed. This is depression. I have to deal with my depression. But really, this is you dealing with stress and managing stress, and well-being is absolutely important, and mental health is absolutely important. But we have to be careful not to just throw terms around to over-normalize them, because then someone who's actually experiencing it may not get the help or attention that they need. So someone who then experiences an episode of major depression, where they have a really significant change in their functionality, where they stop sleeping and they're crying all day and they can't do anything that they formerly enjoyed, well, they may be almost ignored because people are like, whatever, I was depressed last semester too. But this is different. This is leading someone to really have impaired functionality. That's very different than just having a tough time. And so it can be a little bit tricky to try and sort out that gray area and really separate out symptoms. And so that's why it's important to get support from other people, but also be very aware of how we're using words. Because yes, they're just words, but words have quite a bit of weight to them. They matter. They mean something. There's a reason language is so important. They actually mean something. So Christine, I think that's the first step in improving our approach to stigma. And the second step is something that I personally try and do. And you guys have heard me say this. These are brain diseases. And unfortunately, a lot of facilities still call it behavioral health. And that has such a negative connotation, right? This is your behavior. I mean, this is just how you're behaving. Why are you behaving this way? But when you think about it as a brain disease, this is an illness. This is not something that you're volitionally, intentionally doing. And even if it seems like someone is, it can be because of the disruption in their brain chemistry. And so I have a 9-year-old and I talk to her about, some of these conditions, and she's like, oh, what do you do at work? And I talk about it. We talk about weird infections. She always wants to know about weird viruses or weird fungal infections, but then we talk about brain diseases, and I call them that. They're brain diseases. Okay, and I think that's also a really important step as we're trying to contextualize what this all means, that these are diseases and these are not just behaviors. This isn't someone necessarily just acting out. Right.
Thank you.
Great question.
I had a quick question if it's okay,
Yeah,
Dr. Knox. I remember earlier in the presentation, you were showing like different things that you've helped treated in the past, like bipolar and schizophrenia and stuff. One thing that, and correct me if I'm wrong, I didn't see it, was insomnia. Mm-hmm. Is insomnia considered like a psychiatric thing that you've helped treated in the past?
Absolutely. And insomnia is super common for not just psychiatric pharmacists, but pharmacists in just about every setting, because insomnia is so prevalent. So thank you for bringing that up, Juan. It's not usually a reason for primary referral to a psychiatric pharmacist. But many of the insomnia cases that I have had to deal with have been insomnia reported as the first symptom. Because you might go in and see your primary care physician and you don't want to burden them with the way you've been feeling, but you might tell them, my stomach's been bothering me. I've got these headaches and oh my gosh, I can't sleep. I try and I can't sleep. And so oftentimes those types of symptoms will be the first indication that there's actually a psychiatric condition, particularly the physical effects. In addition, when I was a resident, there were several patients who were referred to me who were initially seen for insomnia and may have been referred to me to help get them off of their treatments for insomnia. So many of you guys have probably at one point or another taken an over-the-counter medication like NyQuil or Benadryl, and you notice it makes you feel sleepy. Well, the problem with Benadryl, the active ingredient diphenhydramine, is you can become very tolerant to it pretty quickly. And on a couple of occasions, I have had to help prescribers taper patients off of really high doses because the patients think it's over the counter. I've taken this before, it must be safe. But you keep taking more and more, your dose escalates and you get up to 10 tablets a night. Well, all of a sudden the psychiatrist is like, I don't know what to do. Let's see if the psych pharmacist can help us get this patient off of this medication. So tapering off of insomnia medications has also been something I've more times than I can probably count I've been involved with. Any other questions?
I have a
Hi,
question.
Dr. Oh, go ahead.
Go ahead, Dana.
Okay. So I have a question. Before you joined the UCI School of Pharmacy, can you talk about how your day in life was like as a psychiatric pharmacist?
So when I was at CAC Hospital at USC?
Yes.
Okay, sure. So Dana, it's interesting because I would call myself a psychiatric pharmacist there, but that was only about a quarter of my day. And for a long time, I considered myself a psychiatric pharmacist pretending to be a critical care pharmacist. Now, after 14 years, I think I probably could safely call myself a critical care pharmacist, but in my heart of hearts, I knew I was always a psychiatric pharmacist. So the interesting thing was over there, I worked 12-hour shifts. So my day was long, but I would usually work 3 days a week. So long days, trading that for days off. Normally I would come in the morning and first thing I would have to look at my ICU patients to see if there was anyone critical, anyone crashing. And I would prepare for my ICU rounds. And we had some amazing attendings who were very reliant on us to provide them with all of the appropriate medication management. And if you guys were at Dr. Mark Bahe's presentation, I think a few months ago, he talked a lot about critical care pharmacist and what the role is. I listened into about half of his presentation with the P4 Janelle. So I would do my critical care stuff first because that tended to be much more time sensitive. In addition, psychiatry tends to start a little bit later. Critical care starts at like 5 in the morning. They're there early. So my shift started at 6:30 and things were already cranking. Psychiatry, yeah, around 8:30, 9, they kind of roll in a little bit later. So they work on a slightly different schedule. What that meant was I really didn't get to my psychiatry patients until the afternoon. Plus, when I worked with the cystic fibrosis patients, they tended to be afternoon appointments because their clinic block was from 1 to 5. So I would do all my critical care stuff from about 6:30 a.m. till about 12. It was usually somewhere around 12 or 12:30 that I would pull up my list of psychiatry patients. So we had a list of patients that we were regularly following. At that point, usually if I had a resident or a student on rotation, the resident or student would have already gone with the team to start seeing the patients right around 9 o'clock. So then the resident or student would come to my pharmacy, my satellite, and present the patients to me. And we would all get together at 1 o'clock and we would talk about the patients. So it would be the med students, the psychiatry residents, the psychiatry attending would finally come in, the pharmacy student or pharmacy resident, and me. And we would all talk about the patients and come up with a plan. And so it was a very collaborative effort. Oftentimes me and the attending would then go see the patient just to verify what the residents and students were presenting. And then my student would go and they would write some of the notes. The med students would write some notes. Me and the attending would kind of go off and then we'd come back and co-sign notes at the end of the day. With the cystic fibrosis patients, they would call us and tell us when our psychiatry cystic fibrosis collaborative patients were coming in. So I would go see them in the clinic. So since it's cystic fibrosis, they're more likely to have multi-drug resistant organisms colonizing their lungs. So we would have to fully gown up. So what you guys see now for COVID patients, we were doing full masks, gloves, and gowns for cystic fibrosis patients prior to all of this. So it was a very familiar process. We'd go in, we'd talk to the patient. It would usually be me and the psychiatrist because we didn't have a huge team. We don't want too many people going in those rooms. We would see the patient, we'd talk to them, we'd talk through, come up with a plan, and then we'd come out and the psychiatrist would usually put in the note and I would stay in and talk to the patient, answer their questions about the new medication we were prescribing to them. Then in the later afternoons, I would do phone calls to the cystic fibrosis patients, usually around 4 or 5, who we had seen in previous weeks, to check in and see how they were doing and do some symptom checks. Then I would also meet with the resident and the student, possibly do some of my scholarly work. But, you know, I also had ICU to take care of. And so all of the follow-up from the day would come through and then I'd be there till about 7 and I'd run out the door at 7:07. I think someone else was going to answer or ask a question when Dana was asking.
Yes, I have a question. So I know you said that there aren't that many board certified psychiatric pharmacists, but I was wondering, since it is quite specialized, do you think it'll be difficult to find a career in this field if we are interested?
Yeah, so the interesting thing about psychiatric pharmacy is psychiatry has been a huge push, Jenny, in the VAs. So if you have an interest in working in a VA setting, they're expanding their services. They've had multiple federal mandates saying they need to increase the psychiatric care of the veterans. I think historically it has been fairly poor. It hasn't been well supported. So there have been multiple reports that come out about how we don't have enough psychiatric providers. And so for that reason, what you'll find is a lot of opportunities within the VAs. There are opportunities in academia. And, you know, psychiatric pharmacists don't have to do psych 100% of the time to be effective psychiatric pharmacists, as evident by Dana's question asking me about what I did at Keck. I did quite a bit of psych, and even still, I get texts from those psychiatrists because I have the unique perspective of being able to balance both. So I think if you can recognize that as a psychiatric pharmacist, you have a role in settings outside of psychiatry, then you know the jobs are endless. You could work in an emergency department, and I can't even count the number of times that I have had to in an emergency department use my psychiatry knowledge. So psychiatric pharmacy is applicable in critical care, in ED, in transplant settings. The transplant pharmacist texts me and asks me questions. So those chronic care settings where it gets a little bit more complex than just kind of your run-of-the-mill psychiatry patients. All of those areas a psychiatric pharmacist can have input. And so if you're willing to be a little more flexible and not pay so much attention to your title, then a psychiatric pharmacist has opportunities in lots of different areas. But if you really want to do psych most of the time, there are opportunities for that as well, especially in VAs.
Thank you.
Thanks, Jenny.
All right, we have time for one more question if anyone has one. You can also send it in the chat too if you're more comfortable that way.
I'm just happy to see so many faces. This is great. Instead of just black screens with names. Thank you guys for turning on your cameras.
Oh yeah, I was wondering if is there like a specific branch for pediatric psychiatric pharmacy, and if so, like is it like different, or like does it kind of fall in the same branch? Because I'm interested in working with pediatrics in the future.
Yeah, so great question. Pediatric pharmacy is different than adults because they are often not the ones making the decisions about whether or not they're going to agree to a certain medication. So my experience as a resident was actually with Edelman Children's Court, where we were working with the children in the foster care system. Essentially, the judge is acting as the decision maker for psychiatric care for these children. And we would do home visits, me and a pediatrician. I was there as a resident, or the psychiatrist and the pediatrician, when there was no resident there, would go see these patients in their homes. And we would do those because they were being seen by a psychiatrist. So community psychiatrists can see them, but if they want to prescribe a medication, they have to go through the courts and the judge makes the final decision. So there are those types of considerations when dealing with pediatrics. You have to be able to speak to not only the child suffering from the psychiatric illness, but also the caretaker. And that caretaker could be a foster parent, it could be an adoptive parent, it could be a grandparent, it could be a temporary caretaker, or it could be the biological parent. So you have multiple different people who you potentially could have to interact with to explain the reasoning behind needing a psychiatric medication. In addition, when you're dealing with pediatrics, there's less data because it's much more difficult to study. So we haven't studied a lot of our medications as thoroughly in pediatric and adolescent patients as we have in adults. And so for that reason, sometimes you're dealing with medications that are not approved by the FDA. So you're using off-label, which means you have to have a lot more reasoning behind it. You have to be able to defend it. And so it can be a little bit more challenging. I wouldn't say it's necessarily a subset, but it can be a little bit more difficult because not all psychiatric pharmacists practice with pediatrics. At LA County, my former residency program director is actually a psychiatric pharmacist dealing particularly with adolescents, and that's her area of expertise. So during your residency, you have the opportunity, hopefully, to have a pediatric rotation, then I would recommend taking it.
Thank you so much.
Thank you.
Okay, that is all the time we have today, but thank you so much, Dr. Knox, for coming today. That was a wonderful presentation. Can we get a warm round of applause for Dr. Knox, please, everyone?
Thank you guys for having me. This was fantastic. And on my question slide, obviously my email is right there, and I'm happy to answer questions. I've met a couple of you guys in person, so Jenny knows I don't bite. I'm nice.
Okay, before we end the meeting, could we take a group picture, please? And then Chantel, whenever you're ready, you can count us off.
Okay, everybody, be taking the picture. So 3, 2, 1. Okay, let me do one more, please. Sorry. Okay, 3, 2, 1. Okay, thank you so much.
Alrighty, thank you. And thank you so much, Dr. Knox, again, for taking time of your day. We love the presentation. It was awesome.
Thank you guys for having me. Have a good evening, everyone.
Okay, and now I will hand it over to Ryan.
Hi everyone. So this kind of concludes like the official part of our general meeting, but we're going to take a photo to help us participate in the I Love You My Org or competition. If you're interested to participate, you can stay here. If you're not, you can, or if you just want to go to ready to our after social, you can hop onto our Discord too. But I'll give you guys like 1 or 2 minutes to decide whether you want to participate or not, and then get ready for some of the stuff that we may want you to do, because they help to qualify for the photo. So some of the topics that they want us to do is if it's possible, it would be great if everyone can have the PPS Zoom background with their camera on as the as a somewhat the minimum requirement from them. And if not, we can also do a winter accessory one. See if I have the some sort of scarf, gloves, beanie, or hoodie. That also works really well too, to fit out into the as a winter winter theme. And if you have any PPS merch, like my t-shirt here, if you have a pill bottle, that also works too. Stickers, Jamba juice cards, or whatever you have that's PPS related. Or if you don't have these stuff, you can also do your like small heart sign, or like you can do your Zod. So if that's cool with everybody.